the body fat is comparatively higher in females and the total body water is comparatively less in females. When we talk about the respiratory system, the lung volumes is lesser in females. The lung area available for diffusion of gases is lesser in females. The exercise-induced hypoxemia is higher in females. The ventilatory responses to hypoxia and hypercapnia, the responses what we see are lesser in females. The brain and the central nervous system, which are the main target organs for the anesthetic drugs, they are sexually dimorphic right from birth and they continue to differentiate throughout life. So, gender has a substantial effect on the influence of various anesthetic agents in the brain and CNS. In the gender differences in relation to the autonomic nervous system reactivity to stress, we consider perioperative period as a state of stress, and the differences in the response to stress would be a major consideration when we are considering the anesthetic responses. When a surgeon operates on an appendix or a parotid or a thyroid, the surgical stimulus given is nowhere different between the males and females, but the responses that are occurring in the female body are different compared to males. The human and animal data indicated that sexual differences exist between the male and female basic autonomic function itself, and when the responses occur, the sympathetic stimulation is predominantly prominent in males and parasympathetic stimulation, the responses are predominant in females. Studies suggest that there is an attenuated response to stress-induced plasma catecholamine release in females, implying that females are less sensitive or less responsive to the adrenal medullary activation. Sympathoadrenal activation is attenuated and inhibition is augmented in females compared to males. There are also the differences in the neurohumoral responses to hypoglycemia. The responses to hypoglycemia are seen much later and at a much lower blood sugar levels, and the responses are much less pronounced and blunted in females compared to males. The preoperative anxiety is known to be more in females compared to males. And one more aspect, the next aspect, the pharmacokinetics. In humans, it is estimated there is a 40% difference in the pharmacokinetics between men and women. As I discussed in the physiological differences, women have more body fat and lower muscle mass compared to men, and the total body water is lesser. The water-soluble drugs such as muscle relaxants have a lower volume of distribution, and the lipid-soluble drugs such as benzodiazepines, opioids, propofol have a larger volume of distribution in women compared to men. With respect to oral midazolam, it has been seen that women have a higher bioavailability. The plasma cholinesterase. This is a very important enzyme for the anesthetists. The activity of plasma cholinesterase is higher in men and in postmenopausal women. Use of estrogen-containing oral contraceptives have known to cause a reversible decrease in the plasma cholinesterase activity. Do women react differently to the general anesthetics compared to men? Overall, it has been observed that the women emerge faster from anesthesia compared to men. They have a higher risk scores at similar target plasma concentrations. That means when a similar amount of drug is used and they achieve a similar plasma concentration, the risk scores are higher in females compared to males. So we need to modify our anesthetic techniques to maintain a lower risk scores. There is an increased risk of intraoperative awareness among women owing to this reduced susceptibility of the women to anesthetic agents, especially the hypnotics. The neurosteroids such as pregnenolone, which is a progesterone derivatives, have got some anesthetic properties. The increased production of progesterone during the luteal phase of the menstrual cycle and pregnancy may have an impact on the anesthetic drug requirements. Both the intravenous and volatile anesthetic agents we all know that they cause a decrease in blood pressure on induction. The fall in blood pressure is more pronounced in females compared to males. The pharmacokinetics of propofol. If females have a lower plasma level of propofol, in spite of the similar dosing given, the young and old females seem to need a 10% higher infusion rates compared to the males to maintain the similar plasma concentrations. Studies have been done even in the elderly females where the actions of reproductive hormones would be less. Even in the elderly females, it has been found that gender differences in the pharmacokinetics of propofol. Next, the most important, or I would call the most important aspects of analgesia, the opioids. Morphine-induced analgesia, it is greater in females. Buprenorphine have higher plasma concentrations in females. The mixed mu-kappa opioid agonist antagonists like nalbuphine, butorphanol and pentosecin, they have a better efficacy in females compared to males. The opioid side effects are more pronounced in females, especially the post-operative nausea, vomiting, respiratory depression, the chances of opioid addiction and opioid-induced endocrinopathy. Coming to the muscle relaxants, females seems to have a more sensitive to non-depolarizing muscle relaxants. They have the dose requirements is 30% less and in relation to the rocuronium, atracurium and vecuronium. No differences were observed in the onset and clinical duration of cis-atracurium. The adverse drug reactions to neuromuscular blocking agents were found to be higher in females compared to males. Pain on injection of rocuronium is found to be more in females compared to males. Anemia is a very relevant topic for the anesthesiologist. Though it may not be directly related to anesthesia, I have included in my talk for the reasons I will be telling you. Iron has a heme role and a non-heme role. Heme role, as we know, it is required for hemoglobin synthesis. In addition, it is also a cofactor for many enzymes which are involved in the maintenance of homeostasis. The total iron stores in the human body are comparatively more in males. Females seem to have a disadvantaged position with respect to iron metabolism. It has been estimated that more than half of the female population suffer from iron deficiency anemia at some stage in their life. The systemic analysis of the global burden of disease 2016, the recommendations say that the findings say that the number of years lived with disability is more with iron deficiency and the propensity is more in women. In iron deficiency, the anemia, if it has to manifest, it clinically manifests much later because erythropoiesis is often preserved until the advanced stages of iron deficiency. And much of the burden of iron deficiency in women would go unrecognized if the absence of anemia would be assumed to imply adequate iron stores. When it comes to intraoperative blood loss, because of their inherent physiology, blood loss of similar quantities would be, if you calculate, the proportion of loss of hemoglobin would be more for females compared to men. Added on to it, inadequate or the low iron stores would imply that the body will have a less ability to sustain the erythropoiesis to recover the blood loss from surgery. Post-operative anemia is found to be even more common in women, ranging up to 40 to 60%. The reason could be the associated blood loss of surgery and added on to it because of the pre-existing anemia itself. Women are at a higher risk of requiring transfusion in the perioperative period. Iron deficiency anemia, it accounts for 75% of the preoperative anemia cases. Another entity, that is iron deficiency without anemia, is much more common than the iron deficiency anemia itself. Even mild anemia is known to be an independent risk factor for post-operative morbidity, prolonged recovery time and length of hospital stay, requirement of blood transfusion in the perioperative period and the risks associated with transfusion. The iron deficiency anemia, the diagnosis of this currently depends upon the hemoglobin levels, ferritin levels, transferrin levels, etc. But we all know that serum transferrin values are unreliable in the presence of inflammation or infection. Further research into the use of newer biomarkers is needed. Since females are highly prone for iron deficiency, the international consensus statement on perioperative iron deficiency and anemia, it has emphasized the importance of screening and management of iron deficiency without anemia prior to surgery. Over half of the female patients presenting for major elective surgeries have some kind of iron deficiency, whether it is absolute or functional. So, these candidates may have to be screened and managed with perioperative iron therapy. Then the next question, the preoperative hemoglobin levels acceptable for major elective surgeries. We know that we accept a lower threshold of hemoglobin for females compared to males. So with these points, we may have to redefine the normal values of hemoglobin in women in the perioperative period. We need to justify whether it is acceptable to continue with the current cutoff hemoglobin levels to define the hemoglobin thresholds in the women in the perioperative period. The recommendations state that the perioperative anemia, the recommended statements by the international consensus statement state that a target hemoglobin of more than 13 should be acceptable irrespective of the gender of the patient, and a hemoglobin level of less than 13 should be considered as suboptimal and managed accordingly. The next aspect, pain. We all consider ourselves as pain warriors. So let me highlight some points where differences of pain response in females. Are women more sensitive to pain? Research findings have been done, and the findings of over the last 4 decades have shown that there is some discrepancy between the pain response in females and males. Compared to males, women experience more intense acute pain and pain of longer duration. The reasons have not been fully explained, but some theories have been postulated. Gender-related cortical differences have been seen in the processing of pain-related stimuli, implicating a differential brain activation. Women show a greater temporal summation of pain. Biological gender differences have been found in the ascending pain transmission pathways and descending pain modulation pathways. Women don't have the protective effect of testosterone because of the inherent biology. Testosterone is found to be more anti-nociceptive. The estrogen and progesterone's effect on the pain sensitivity are relatively complex, and both have been shown to have a pro-nociceptive and anti-nociceptive effects. Many meta-analyses have been done and experimental studies have been done, and it is revealed that women have a higher pain threshold and tolerance during the follicular phase of the menstrual cycle compared to the luteal phase. Some studies have shown that there is an increased reactivity to pain in the perimenstrual period and mid-cycle phases. The endogenous opioid system is found to be different in men and women. Distinct differences are found to be there in men and women in relation to the brain mu opioid receptors. Many studies have been done, not just the gynecological surgeries and obstetric surgeries. Studies have been done in orthopedic surgeries to assess the pain differences and the pain perception differences in males and females. What do we do when we try to assess pain? We look at the sympathetic responses. We assess the heart rate and blood pressure. As I have told in the differences in the autonomic nervous system, we have seen that the response itself are blunted. The autonomic responses itself are blunted. So increase in the heart rate in response to surgical stimulus is considered as one of the measures to modify your anesthetic technique or supplement your analgesic or increase the depth of anesthesia. So we have to question ourselves whether the heart rate variability in response to pain, since it is inherently different, do we have to still rely on the heart rate response to pain in females? The gender pain gap. Research studies have been found that the healthcare providers, they underestimate the pain in women compared to men. A pain score of 8 by 10 in women would elicit a different kind of treatment than a pain score of 8 by 10 in man. The healthcare professionals are more likely to perceive the pain of women as hysterical, emotional, complaining, or even fabricating their pain. Healthcare providers have been observed to have a tendency to prescribe psychological treatment for women and analgesics to men. The concept of chronic post-surgical pain persisting even after 6 months or a year after surgery. Female gender is considered to be an independent risk factor for chronic post-surgical pain. Many chronic pain conditions are more prevalent in females compared to males. The next aspect, the post-operative nausea vomiting. Post-operative nausea vomiting is a very distressing symptom. It is commonly reported after surgery, and female gender is considered to be an independent risk factor for PONV. The APGAR scores have suggested that in a female with added use of opioids, the risk of PONV increases to 60 to 70%. The correlation between the menstrual phases and the frequency of PONV has been studied, but there is no firm evidence linking the specific phase of the cycle to the occurrence of PONV. The high incidence of PONV in a premenopausal woman has been associated with higher levels of estrogen, but the cause has not been fully proved. A female patient undergoing a major surgery with a post-operative and perioperative use of opioids is considered at a higher risk of PONV regardless of her age, and in such patients we should go for a multimodal approach for PONV with more than 2 interventions. Additional strategies have to be taken care, like minimizing the use of perioperative opioids, going for multimodal analgesic regimes, preferential use of regional anesthesia, and preferential use of propofol infusions. This flowchart is about management of the PONV. If we look at the middle part, we can choose 2 or more interventions like 5-HT3 antagonists and dexamethasone in female patients. The recommendations here is that go for at least more than 2 interventions. The PONV in daycare surgeries. One of the major reasons for delayed discharge after daycare surgery is known to be PONV. The SAMBA guidelines for PONV management say that when the risk factors are more than 2, as we see in a female patient, we should go for more than 2 interventions. And a note on the anesthesia and oral contraceptive pill. Opioid OCP use is associated with the increased risk of perioperative thromboembolism, and it is more with the desogestrel containing OCPs. Some modifications have to be done in the perioperative period. We should consider stopping OCPs at least 4 weeks before the major elective surgeries, and if it cannot be stopped, You can add it with the subcutaneous heparin. Graduated additional measures for venous thromboembolism have to be taken. These recommendations would not apply for ambulating patients or minor surgeries where they are expected to ambulate early. We all know that OCPs are not just used for contraception, they have got non-contraceptive benefits also. So when we stop the OCPs in the perioperative period, side effects such as withdrawal bleeding, mood changes and return of endometrial pain may occur, and it could affect the perioperative outcome. Contraceptive failure has been known to occur, and one of the drugs of anesthesia, that is Sugammadex, has been known to be related and known to have a effect on OCPs. A single bolus dose of Sugammadex is thought to have been equivalent to missing a single dose of oral contraceptive. So nowadays the recommendations are there to revise your anesthetic consent. They are thinking whether to add a word which includes the following statements: if you are using oral contraceptives, consider alternate methods of birth control for next 7 days following the anesthetic. Not just the reproductive age group, the gender-related mortality has also been studied in pediatric female surgical patients. It has been noted that female gender is associated with a higher hospital rate, in-hospital and 30-day post-discharge mortality rate, and female gender is considered to be an independent risk factor for increased length of hospital stay. Gender is believed to be an independent risk factor for the development of post-dural puncture headache. Females tend to have a higher incidence of post-dural puncture headache. To conclude, nearly half of the surgical population is females, and exclusion of females in anesthesia-related research studies has left us with a huge knowledge gap in literature, and we need further research in trying to find out why anesthesia is different in females compared to males. These are my references. Thank you.
Thank you, ma'am, for this knowledgeable session. I will now request Dr. D.S. Patil to hand over the microphone to Dr. A.
Hello. The topic is open for discussion or not?
Yes, sir. Go ahead, sir.
Hello. Thank you very much, madam, for nicely explaining this difficult topic. As a practicing anesthesiologist, I am asking a very simple question. When I go for what important point I should remember when I am anesthetizing female patient? I am asking you summary of the big topic. Few words. What are the precautions I should take for induction, drugs, and recovery?
In the preoperative assessment, few points have to be asked additionally. That is the history of the LLP, then history of POLP in the previous surgical experiences, issue on any pain-related medications, because chronic pain conditions tend to be occurring more in females, and general anesthetic variations would be variations in the drug dosages, and in the intraoperative management, we should try to cut down on the opioids and take more precautions in the intraoperative period itself to prevent post-operative nausea and vomiting. And as I told regarding the hemoglobin levels, we should try to find out whether they have iron deficiency itself. So maybe we will need to evaluate more. And currently the biomarkers which are available are not suitable to detect iron deficiency. Maybe we need more of the tests.
If the iron deficiency is, I think, hypoprotein is usually here, usually. Proteins level will be also less.
Yes.
So drug dosage will be less, no?
It is not just the nutritional iron deficiencies, it's...
I know, understood. Yes.
The loss is more compared to males. The loss of iron is more in females compared to males. And the erythropoiesis is not different. They don't have a stepped up erythropoiesis. The loss is more. They don't have a stepped up erythropoiesis. So the chances of iron deficiency are more. And we as anesthesiologists, I think iron is an important mineral for us.
Okay. When lady pain comes with during period as an emergency, what precaution anesthetic has to be taken as far as our drugs are concerned? You have explained everything, but it is a little vast subject. But during practice, if the patient is in bed and requires emergency surgery, any suggestions you would like to give us?
We need to modify the drug dosages and we need to cut down the opioids. The induction response that is the induction hypotension that occurs in females, the chances of hypotension at induction is more in females compared to males. So we have to take care of that. We have to take care of the pain. The assessment of pain would be different in females compared to males, as I explained. So maybe we need more attention to a female's pain. That is one aspect. Anemia is another aspect. PONP is another aspect. And maybe we need to arrange our anesthetic equipment according to the size.
Now topic is open for discussion. For judges, staff, anybody wants to have any questions and doubts, you can ask questions to madam and discuss and get clarified.
Good morning, madam. First of all, congratulate Vidya madam and Dr. Renuka for this wonderful topic. In this days of wokeism and overspent gender equality, I think it has opened Pandora's box. Saying that women are more sensitive and they have got their own requirements. And nature always knows that. Women are special and they need special care. Of several points, one of the point is anemia. Whatever WHO standards are quoted, I don't think they are suitable for our practice. I have not seen a lady coming to anesthesia having 13 grams of hemoglobin. Maybe it is in once in a blue moon. So we don't meet this criteria. We need to set our own standards in India, where we have to categorize what is anemia for Indian ladies. This is the first point. The second is, if we go by Western standards, we cannot anesthetize any female patient in our center, or maybe 1 or 2%. So our requirements are different. So I request and I see our Indian Society of Anesthesiology is working on this aspect and setting the guidelines separately for this. Other point is appreciation of pain. Yes, definitely yes. Though they have set example for millions of years giving birth with intense pain, but still their pain experience may be different. So our sensitivity should be more for the pain of lady patients. Otherwise, actually, it is other way around, and we say that you have to tolerate this pain and you are good at it and you so and so forth. We bullshit on this now. You have opened our eyes to this aspect very much. Thank you so much for that. Thank you.
I would like to say a few words here. When Dr. Renuka said that she wants to talk on this subject, we all in our department were a little apprehensive and were just wondering what she would like to address. And we were not very encouraging, in fact. But then she stuck to that topic, and the credit should go totally to her, sir. And she's done a wonderful job.
And I am really grateful for allowing me to go ahead with this topic.